why don't we begin with one of the questions from Ann Thackeray. And she asks, she says, thanks for sharing your work. Great presentation. As you explored the needs of individuals, I think she put this question in while you were talking, I believe, about the development of the toolkit. Did you examine or get feedback on incentives or motivations, either internal or external, to implement evidence-based practice?
You know, that is a really great question, especially as we think about motivation kind of serving as a mechanism that can influence implementation, certainly. And admittedly, I'll have to say that we didn't specifically look at or ask practitioners directly in our knowledge translation survey about incentives or about motivation. Rather, we were naturally hoping that those types of comments would come to light via those survey responses. But I think you bring up a great point for what we're doing right now currently in our ISTROM studies, the stroke rehab study, in the sense that we're still gathering information from our practitioner stakeholders and asking questions now in this early phase about motivation, about incentives, I think could be really powerful as we're designing our implementation strategy package. And so I very much appreciate that recommendation or that point, because that is so important to think about as we think about as clinicians who are so many competing demands. What is really going to serve as those motivating factors to incentivize them to implement both the Fugl-Meyer and the ARAT, when again they've got so many other expectations that are set forth on them. So thank you. I really do appreciate that.
I think it was very interesting that in the ISTROM study that your identification of determinants was done through a scoping review only, and then your qualitative research then was about feedback on the strategies that might be most effective for the setting. I think some folks would do the qualitative, as you mentioned, the qualitative research first to identify the determinants or pair it with the scoping review. Can you just talk about the different approaches?
Sure. And I think that, you know, on a very straightforward, my knee-jerk response to that is just logistics, where, you know, having access to qualitatively the right group of practitioners, having the resources to incentivize them to participate in some focus groups or one-on-one interviews. The literature was just available to us. And I've seen this work done, again, not to plug him again, but Byron Powell's work. I think one of his studies, the acronym is COSTIS, and I'm not going to be able to remember what that stands for. But similarly started with a similar process, turning to the literature first, but then of course, making sure to vet those implementation barriers with a subset of practitioners or providers who could further kind of flesh out what those barriers actually meant for folks who are really providing frontline care. So I guess in terms of your recommendations, or to answer your question a little bit more directly, I don't have a recommendation for what's best. I just think that it's mixed methods approaches in implementation science. I'm very drawn to those because the quant data, in this case, the scoping review data, only tell one side of the story, and we really do need that qualitative data to help us understand the depth of the issues that our practitioners are experiencing.
Thanks. There's a question for Jennifer Vincenzo also about that study, asking how you were able to determine the baseline use of the Fugl-Meyer and the ARAT. Was the EHR already set up to pull that type of data to look at baseline?
Yep. Great question. Because we're lucky in the sense that Ohio State's Med Center does already have fields built into, we use Epic here as our EHR, and already had fields built in to capture just aggregate scores of the ARAT and the Fugl-Meyer. And so we're able to make a request, a data pull, looking at those. We're still in the process of doing that to get our sound baseline data, but we're able to make that request and look at trends or at least the patterns of ARAT and Fugl-Meyer use over the course of the past year prior to deploying ISTROM to get a sense as to what those numbers look like. I will say some of the work that I've done in more of the community-based social service setting, which I know is a different shift here, but I'm sure has some parallels for folks that might work in non-academic medical center settings. We've gone through and manually extracted from narrative notes what evidence-based screening tools or assessments have been used. And we've done that on a subsample of charts, not every single one certainly, but that has been kind of the more labor-intensive way of evaluating baseline implementation rates. So you've got two options. If you're lucky, you ask for the data pool, and if not, you've got the manual extraction.
Great. Here's a question from Monica Robinson. She asks, in your experience as a practitioner, do you believe LeaRRn is expansive enough to capture strategies unique to therapy, such as various education and training needs?
I know Monica Robinson quite well, and it's always giving me the tough questions. I've heard Byron Powell speak before at one of the Dissemination Implementation Science conferences. And he once referred to his list as just that, a list of strategies to give you kind of a starting point. And so if I'm being totally transparent here, I don't think that the list alone is sufficient enough for really understanding what mechanisms influence implementation of best practices. And I think that's a widely echoed opinion or perspective. And however, one way to kind of navigate around the fact that the LeaRRn taxonomy is just a list is turning to some of Enola Proctor's work, where she's made recommendations for how to clearly specify the implementation strategies that you do deploy. And so when I say specify, that those are the details about who is delivering the implementation strategy, what is the dosage of it, how frequently is it delivered, being really clear in your description of what is included in that implementation strategy. Training, as we know as practitioners, is a very common implementation strategy training, CEU courses, workshops, but it's hard to really understand why a training might lead to increase in practitioners' ability to implement something in practice, because the trainings are often so multifaceted and complex. There's, of course, there's the didactic components of training, there's self-reflection, there's, metacognitive techniques that might be embedded in those training sessions. So it's hard until we get better at really specifying and clearly describing what those implementation strategies look like. It's hard to know what strategies are really most effective for improving implementation overall. That's a great question. And it's definitely an area in the field of implementation science that continues to evolve. Carol Lewis is doing some really nice work in this space of specifying implementation strategies further. And so it will continue to evolve rapidly, as many different areas in implementation science do.
Thanks. There were two questions about EHR use, and I want to, before we get too far away from the conversation about how we capture data back in the EHR, I'd like to ask them together. Namrata asks, she says, we have EHR fields set up, but therapists are not able to use them since they are busy and utilize free text boxes in notes. Any tips on getting therapists to complete them? And then Alexandra asks, can you talk more about the logistics of the interactions with the IT group to pull EHR fields? How long has the process taken? What have some of the challenges? And have you included IT stakeholders in your grants? To me, those questions are related, but
yeah, and it's really, when it comes to this type of implementation work, these are the types of questions that people want to know the answers to. Like you can use the CFIRD matching tool, you can qualitatively evaluate your CFIRD determinants or identify your CFIRD determinants, but it really is the how-to that makes or breaks an implementation project sometimes. And so the first point about how do you get practitioners to fill out fields if they're already made available in whatever your EHR system is. And that's not something that we came up with on our own. We, as part of our ISTROM grant, we have our outcome measure champions who don't necessarily serve as co-investigators, but are key personnel representing acute care, inpatient, as well as outpatient. So once the study started, they were immediately pulled in. We as the research team understood what the layout of the EHR was. And so we were able to brainstorm collaboratively. And that's the whole, the take home from this talk is really that stakeholder engagement piece. And so we were able to think collaboratively about how we might change the setup of the EHR, embed those fields, the ARAT score field, as well as the Fever-Meyer field, directly in flow sheets that practitioners fill out upon initial evaluation. And so instead of them having to separately locate where that ARAT flow sheet or where that ARAT field might be located, they themselves were then prompted in the eval sheet to fill that out. And now granted, we've not yet launched iStrom strategies, and so we're not necessarily looking at how effective that was for embedding those fields directly into the OT eval. But we will be looking at, and I'd love to talk about updates and share updates as this project progresses. The other piece, though, Linda, remind me, because I might have already lost it. It flew out of my mind.
The first part was, how do you get therapists to use the EHR fields, and then how do you work with IT, and how long does that process take?
Right, and so the piece about adding the fields to the flow sheet, we're hoping that will be helpful. We have collaborated as part of this early stage of our project. We have collaborated with an IT representative at Ohio State who does coincidentally have a rehab background, and so we're very fortunate for that. And so he's been instrumental in helping us think through how do we make those data pulls, how do we set up the flow sheets in a way that will allow for sufficient data extraction so we can gather those baseline data points. And so again, pulling in those key stakeholders early on in these projects, I think are incredibly important. And she might have been on the call, Lindsay Herman-Matthews with Ohio State. She also has been very instrumental in helping us think through problems, requesting data from what we call our information warehouse here at Ohio State. So it really does take a village, and implementation always does. And so we got to pull in those stakeholders, not just early, but throughout all of our projects.
Thanks. There's a question from Susan Lynn. She says, thank you for your presentation. I presented about SR evidence for stroke interventions for OTs several years ago. And from a poll of attendees, I was surprised that some OTs still use NDT. I'm not against NDT, but I emphasize what the evidence says about its outcomes. Can you talk about de-implementation strategies?
Whew, Susan, I wish I could talk about de-implementation strategies. I would love to get into that work because what you're speaking to reminds me a lot of AOTA's initiatives, as well as other professional organizations' initiatives to using the Choosing Wisely campaign to de-implement those practices that are no longer effective but are commonly used. And so I'd like to think about de-implementation as being kind of this two-pronged issue where when you de-implement something, I've noticed that there seems to be this trend, which makes sense, that if you ask practitioners or you deploy strategies to de-implement practices, that you also at the same time have to introduce strategies to implement new practices that can then replace those older or more ingrained practice patterns. And that just adds an additional layer of complexity, of course, because human nature, we like what we like, we play to our strengths, and we have to be thoughtful, very much so as implementation researchers, about how we're going to carefully walk the line and introduce evidence to practitioners that might indicate what they've been doing for years is not necessarily quite as effective as it was once believed to be. And so that's a very tricky dance. But I think that along the lines of just human behavior, that implementation science can really be bolstered by infusing more theory. So not necessarily models and frameworks, but infusing more behavior theory into our development of implementation strategies or our development of de-implementation strategies. So that theory piece, I think, is really, really important as we continue to put together implementation strategy packages.
Yeah, I think that would be an interesting topic of a future session, really talking about de-implementation and how that might be different.
Yeah, because I think that, to your point earlier, Linda, that cuts across not just the OT field, which I know Susan represents, but also all of rehab, as well as just allied health as a whole too.
Absolutely. Another question from Jennifer Vincenzo. She says, how do you cover your clinical champions' time and effort in outpatient, considering when they are not in patient care, they are not just losing FTE, but clinical revenue?
Yeah, it's a huge question. And if anybody was present for the ACRM instructional course on implementation science this past Saturday, this was brought up as well. Fortunately, through the AOTF grant, we do have some funding set aside to help pay for practitioners or 3 outcome measure champions to be, part of the investigative team, more or less. And so they do have a couple hours set aside per week that's covered through grant funding in order to allocate efforts towards, helping us as a team address these implementation barriers, develop our implementation strategies. I fully recognize that that is not the case when grant funding is not flowing, then that's not necessarily possible. And so I do think that having the administrative team on board, and that's probably a different conversation too about how to engage administrative leaders in implementation efforts. And that's actually one of the tools that we included in the knowledge translation toolkit, was really how to create a culture, not just at the practitioner level, but also at the leadership level, how to create that culture of implementation that really does support innovative ideas, that's on the cutting edge of pulling in research into practice. And so I think that while it's a big issue, I think that pulling in not just practitioner stakeholders like we've been talking about, but pulling in managerial leadership, admin stakeholders as well, to get that full multifaceted perspective as to what's going to influence implementation is really important.
Great. A question from Monica. She asks, are you considering to use the framework for reporting adaptations and modifications, expanded the frame for how you adapted the implementation between acute care and outpatient?
That's a really interesting point. Something I'd not actually thought of yet, because when I've used the frame in the past, I've used it to evaluate modifications or adaptations to an evidence-based or evidence-informed intervention. So the thing that is being delivered to patients. But you're right in the sense that there's probably a great value in also tracking the adaptations that we're making to our package of implementation strategies deployed in acute as well as inpatient and outpatient. And that could potentially even be a paper in and of itself, because as what we've learned and what we continue to learn as we talk to our different stakeholders or group of stakeholders is that the needs vary from acute to inpatient and outpatient, and that makes complete sense. And so it might be of good value to other individuals that are trying to transcend these areas, at least within one health system, and increase collaboration across those different areas when it comes to implementing new practices or ideas. And just as an aside or a comment, I think one of the points I want to bring up is that we as a research team didn't necessarily just come to our practitioners and say, hey, we think it's a great idea to implement these 2 outcome measures. But rather, this was more of a collaborative project that came about given this lack of data that existed in acute, inpatient, and outpatient. So if you have a patient that presents to the acute care setting and they're post-stroke, there's not necessarily that upper extremity function data that follows a patient from acute to inpatient and outpatient if they stay in the entire Ohio State system. And so once the individual gets to outpatient, it would be great if those outpatient practitioners had some baseline upper extremity function data that could speak to how much a patient has progressed over the course of their rehab trajectory. Because those numbers, people love numbers, and those numbers look nice not only to payers, not only to practitioners, but are also motivating to patients as well, who might hit a stalemate and become frustrated with their lack of progress as they try to, or at least attempt to progress throughout different phases of rehab. So just as an aside, a point I wanted to bring up in the sense that it's not just us as the research team asking folks to implement these 2 outcome measures. It really is more of a collaborative effort here.
So I think this perhaps builds a bit on those comments. The question from Tyler Beauregard saying, have you found that you have to do any of that culture building work at the professional level, or would it be more effective to focus health system by health system?
This is again reminding me of that instructional course from this past Saturday, is that this idea of process mapping, which is pulled more from the QI literature. And I did see maybe Katie Kwame Yates was on the call a little bit earlier, but that it is so important to understand just within the culture of a system. And I understand that Ohio State University is just one system, and our AOTF grant is just embedded within that one system. But going forward, deploying or launching a process mapping approach to understand, what decisions need to be made, what are the anticipated barriers that we, expect to hit, and what does that process map look compared to a process map somewhere else, a different healthcare system, maybe in a different type of setting, different state, different region. I think that there's a lot to be said for understanding that process first before maybe getting down to the more individual or practitioner level. That's just my gut instinct, and hopefully I'm answering your question. If not, Tyler, we can certainly talk about it offline as an OSU PhD student that you are. But I do think that it's important to understand that culture before looking more at those individual level factors.
Great. And I haven't been ignoring your question, Beth, but I feel like this is a good, perhaps a closing question, depending on how long we discuss it. But Beth asks, looking back at the toolkit development process, is there anything you would do differently now when developing a toolkit? And I guess I would like to add to that for your comment, how do you see this toolkit needing to be modified for other rehab disciplines?
Yeah, so that's a really great question. And I'm hesitating because what I continue to wrestle with is that we want this to be effective for changing practice patterns or improving practice patterns, not necessarily changing it. There's several OTs out there and rehab professionals out there that do a wonderful job implementing evidence into practice, or at least the best available evidence into practice. If I would have loved to have had the foresight when we started this to think about, well, how are we actually going to evaluate if this toolkit is effective? Because again, we can create this toolkit, which in and of itself could be considered its own package of implementation strategies. But without thinking through thoroughly at the forefront, what we're going to try to evaluate, I think that would have really shaped maybe our process of engaging different stakeholders, the types of questions that we would have asked early on when we conducted our knowledge translation survey. But now, granted, there's still time to figure that out, but it just really perhaps would have helped clarify in our minds, in my mind, what the bigger end goal here, which of course is to increase the adoption of evidence-based practices. But how are we going to measure that adoption, especially at that kind of larger profession-wide level, which is a tall order, but an important task. And I think we're up for it. We're up for that task. And so if anybody has ideas as to how to measure something like adoption of just general evidence-based practices, I'd love to hear your thoughts, because it does take a village.